Assalamualaikum. I'm Dr. Nadish Bhatt, consultant gastroenterologist at Jinnah Postgraduate Medical Center, Karachi. Today, I'm going to discuss with you about the acute gastroenteritis, which is the most common complaint and the disease, which we all come across with this acute gastroenteritis symptoms more than once in a lifetime. So it's very common in pediatrics group. So I mainly discuss in children about the acute gastroenteritis. So acute gastroenteritis is a common clinical problem in children. Estimates of the overall incidence of acute gastroenteritis range from 1.3 to 2.3 episodes of diarrhea per year in children under 5 years of age. We don't have our own statistics, but each year more than 300 US children die from this illness. So now you can well imagine about where we are standing in Pakistan. If children are dying with gastroenteritis in US, what's the incidence and what's the death rate of the children in Pakistan? And you come across with the news of children dying in Tharparkar due to diarrhea, due to dehydration, and all these symptoms are news में gastro का word आप commonly use करते हैं. So, according to American Association of Pediatrics, defines acute gastroenteritis as diarrheal disease of rapid onset with or without accompanying symptoms of or signs such as nausea, vomiting, fever, or abdominal pain. So, this is very important. Sometimes gastroenteritis is associated with nausea and vomiting, and we use the term food poisoning for this. And sometimes with fever or abdominal pain, and sometimes patients don't have fever or even abdominal pain, but they have diarrhea. So the hallmark of the disease is increased stool frequency with alteration of stool consistency. So what are the causes? Infectious agents, viruses, bacteria, and parasites are the most common cause of acute gastroenteritis. Viruses, primarily rotavirus, which commonly responsible in 70 to 80% of infectious diarrhea in children. Bacterial pathogens are more common in adults group, and it accounts for another 10 to 20% of cases. Parasitic organisms such as Giardia species causes fewer than 10% of cases, and sometimes it causes Giardia causes malabsorption like symptoms. So viruses, rotavirus is the most common virus in children, enteric adenovirus, Norwalk virus, calcivirus, astrovirus, parvovirus, and nowadays there are few reports that even coronavirus can lead to the diarrhea. Bacterial infections are more common in adults, and the Salmonella is the most common. Shigella is the second most common, then Campylobacter jejuni, Yersinia enterocolitica, hemorrhagic E. coli, toxigenic E. coli. Clostridium difficile is common in hospitalized patient. Parasites, Giardia lamblia, Cryptosporidium is common in HIV/AIDS. Winter season, sometimes diarrhea occurs in children in winter season, attendance at a daycare centers, and in adults if they are living in old houses and where there is impoverished living conditions, poor sanitations. History is very important. You have to take the history to assess the severity of the symptoms and the risk of complications such as dehydration, which is very uh, important complication in pediatrics group. The presence or absence of fever, the amount and type of oral intake, and the frequency and estimated volume of emesis or stool are important to consider to correct the dehydration. Stool characteristics such as presence of blood should prompt consideration of inflammatory bacterial disease and much more aggressive workup and intervention. So always ask about the presence of blood in the stools. Travel to the underdeveloped countries. Sometimes patient give you history of traveling to some countries, underdeveloped countries, or in Pakistan if they are traveling from cities to villages, so they develop diarrhea due to the water or contaminated food. Exposure to untreated drinking or washing water sources, daycare center attendance, because there is a lot of contamination in daycare centers. Recent antibiotic treatment, like for the toothache, for chest pain, for urinary tract infection, they lead to the diarrhea. And recent changes in the diet. Physical examination is again very important. The physical examination helps searching for signs of comorbid conditions and estimating of the level of dehydration. Dehydration assessment, it may be most helpful to compare the patient's present weight with the last recorded weight in the chart in children's to assess the degree of dehydration. Clinical sign may also be used to classify the patient's dehydration as mild, moderate, or severe, which we're going to discuss. In assigning patients to category, physicians should use all the available clinical and historical information, not just the physical. So this is very important. Proper history and physical examination for the assessment and for the management. So what is mild dehydration? Mild dehydration in child is 3% of deficit, that is 30 ml per kg. In infant is 5% of deficit, which is 50 ml per kg. Patients usually have normal increased pulse, decreased urine output. Thirsty, you have to inquire about the urinary output from the mother in case of children and from the adults about the urine output. Thirsty, patient wants more water or not, and normal physical examination. What is moderate dehydration? Moderate dehydration in children is 6% deficit, which is 60 ml per kg, and in infants is 9% deficit, that is 90 ml per kg. So it's more uh, concerned in the infants. Patient usually have tachycardia, little or no urine output. Patient is irritable or lethargic, decreased tears, dry mucous membranes, mild tenting of the skin, delayed capillary filling, cool and pale. Then what is severe dehydration? Child has 10% of the deficit, that is 100 ml per kg. Infant is 15% deficit, that is 150 ml per kg. Patients usually have rapid and weak pulse, decreased blood pressure, and urea complete stop of the urine, very sunken eyes in children, parched, dry mucous membranes, tenting of the skin. You pinch the skin and it becomes tan. This is called tenting of the skin. Very delayed refill. So labs, serum chemistry, in mild dehydration, there is no need of sending labs. You just give the patient to ORS. But serum chemistry such as electrolyte, blood, urea, nitrogen, and creatine level, you do not want to change initial in mild, but in patient with severe diarrhea or moderate level of dehydration, you have to send. So hemodynamically stable children, you can just offer them ORS. Laboratory studies should be performed in children who are severely dehydrated and children who are receiving intravenous rehydration therapy. So serum electrolyte levels should also be obtained in children who show signs of hypernatremia or hypokalemia. The presence of gross or occult blood in the stool should raise suspicion of such pathogens as Shigella species, Campylobacter species, and hemorrhagic E. coli strains. Large number of leukocytes on a fecal smear may also indicate inflammatory bacterial process, so you have to go for all the tests. Then the important thing in this is dehydration management. Number one step, calculate the deficit in case of mild dehydration. Infant 5 we already discussed. So according to the level of the, first you have to calculate the deficit, then you have to give the fluid. For example, in 8-year children weigh 35 kg has moderate dehydration, deficit is 60 to 35, that is 2100 ml per day. So you have to replace 2100 ml per day of the fluid to this patient. It's a very simple way. So, and you can give the antibiotics according to the stool culture or bacteria suspected. But first management is the ORS, oral dehydration therapy, in both the adults and children. Most of the diarrheas are subside just with the good rehydration therapy and bowel rest. Like you can offer them soft food, soft diet. Like in children, we usually advise khichdi, yogurt, and banana. In adults, if your patient have fever, have blood in stools like inflammation, you can give them antibiotics according to their bacterial infections. Thank you.